Hello, and welcome to our ongoing series where we discuss telehealth for all things. My name is Dr. Pamela Ograbisz. I'm the Vice President of Clinical Operations here at Locum Tenens and LT Telehealth. I am with Dr. Jamie Threatt, who has been a nurse practitioner for 12 years and is actually a recent addition to the LT Telehealth team as the Program Director for all things telehealth. Jamie, if you wouldn't mind, can you give us a brief background on what you've done in your past before joining LT?
Yes, absolutely. Um, as a nurse, I worked in trauma and emergency medicine as well as the critical care unit. After completing my nurse practitioner program, I worked in neurocritical care and then also pulmonary and critical care. And I joined LT as the Telehealth Program Director in September of 2024.
Very good. Well, we're very happy to have you. And today we're going to focus on the neurocritical care space and a little bit about telestroke. So tell us a little bit about your expertise with neurology and also teleneurology.
Sure. Um, you know, I think a lot of people are familiar with the use case for neurology and telehealth, particularly for stroke, because that is one of the original applications of telehealth. In my experience as a tele neurocritical care provider, we did a lot of we were a certified stroke center, and so what that means is that we have advanced diagnostics and advanced therapies for stroke at our facility that other hospitals, within the state, don't have. And so, how we utilized tele at my particular institution was as peer-to-peer consultation, as well as a true consultative service to outlying hospitals to try to direct the care of patients that were too far away from our specialized stroke center. So we gave a lot of um, timely, important, uh, helping make decisions for patients when it came to administration of thrombolytics, which
Mhm.
are medications that help break up clots that are causing ischemic strokes. Those medications have to be delivered within a max of 4.5 hours from the onset of a patient's symptoms. So, utilizing telehealth to get a very thorough history from family members, from the patient, from the EMTs or paramedics that were involved in bringing the patient in. All of that can be done via tele to get a really good picture of what's gone on with the patient. And from that information, you can it helps to paint a clear clinical picture of whether or not that patient is safe for thrombolytics. In the event that a patient is not safe for thrombolytics, then we have some secondary intervention options that we can discuss with the care team. And a lot of that would involve transfer to a higher level of care, like a comprehensive stroke center.
Excellent, excellent. And let's talk a little bit about maybe on the ICU side of things. So
Sure.
I think that in all honesty, a lot of hospitals, a lot of providers, and probably even a lot of administrators are very familiar with telestroke programs. But
Yep.
I think sometimes where there's trepidation is, can I really then utilize or institute telehealth in my intensive care unit, right?
Yes.
We've established that they've had a stroke. We got that great treatment. Now they need to be admitted. Now, what do we do? Because at the end of the day, they still don't have maybe a full-time neurologist, or
Yes.
perhaps they have an advanced practice provider, a nurse practitioner, or a physician assistant who is not able to practice independently, and therefore they need to perhaps have MD oversight. Maybe let's talk a little bit about what that could look like.
Absolutely. And in my role, when I was a critical care or neurocritical care APP, we were in a similar situation. I work in a restricted practice state, so I do require supervision and a collaborative physician per the law in my state. And what that means is a lot of times, in especially high acuity situations that we often find ourselves in neurocritical care, there is um, a need and an established relationship with your collaborating physician to kind of bring them in. When I worked, we worked a hybrid schedule. So we worked day shift the vast majority of the time, but we typically did a week of night shift per month. And that week of night shift was a unique experience for all of us because we did not have an attending physician in within the hospital walls. So we utilized telehealth all the time in a peer-to-peer capacity on those nights that we had to make really crucial decisions about patients going to the OR, calling in neurosurgery, things like that. And I would say in all telecritical care, particularly in neuro, you can't underestimate the value of a fantastic critical care bedside nurse. And I really that's in person and virtual, but I think especially for the virtual neurocritical care because some of the changes that a patient may exhibit that are extremely significant can actually be quite subtle. And so having a very experienced nurse doing those head to toe examinations, picking up on those maybe subtle change in the patient's speech, maybe change in the patient's strength from one side to the other, a more pronounced facial droop, whatever it is, a really experienced bedside nurse that can then alert a teleprovider to what they have found, walk that provider who's not at the bedside through, what their 8 p.m. assessment looked like versus what their midnight assessment looked like. And, or, other parameters within the neurocritical care space, like increasing intracranial pressures, elevated blood pressures, and sort of having that resource of a valuable, well-trained RN to walk a physician or an APP that might be remote through those clinical changes does allow for rapid decision making. Oftentimes, we're going down for a stat head CT, or we're calling in neurointerventionalists, neurosurgery, or some other specialty. I can think of so many examples in my head. The other thing is, what happens when a neurocritical care patient misbehaves in a cardiology way, and you may not feel like you are as the neurocritical care APP, that's not your area of expertise. You could talk all day long about subarachnoid hemorrhage, about hemorrhagic stroke, elevated ICPs, trauma. But when it comes to a new onset arrhythmia, being able to call in a specialist to help
Mhm.
walk you through that appropriate treatment for that new finding is absolutely invaluable because you may not be you're the person at the bedside in the room taking care of a patient, but having that expertise available remotely is huge, and I think it saves people's lives.
Absolutely. Absolutely. And let's also touch on, because you brought up a great point, which is if you have an experienced bedside nurse, right, that can help you, that's fantastic. We do know that we certainly build programs for sites that don't have that, where the
Sure.
staff is maybe not as experienced or has a lot more questions. And I think the beauty of the programs that we build is that you can also use tele in a much more invasive way, if you
Yeah,
will, right? So
absolutely.
that you can have the nurse literally walk you through the bedside exam and
All
say,
the
put
time.
the camera here, ask the patient to do this, do that, and we're able to also essentially guide, right, the entire staff. We have had where we've had folks, code on camera, and you're
Absolutely.
actually giving the orders to the staff that's in the room until the code team arrives. So tele is, as you said, right, multifunctional. The way that it can be utilized, and for both experienced and inexperienced, it can work both ways. So I think that's great. How do you think that telehealth has changed the landscape of neurological care?
Oh, I don't think you can underestimate that. I think it's massive. I think obviously we have the most examples of stroke is probably the thing that most people think about. But I would also, point out that a lot of patients who require the specialty care of a neurologist, most of them, in fact, are suffering from chronic lifelong or life-limiting conditions. And a lot of those conditions come unfortunately with a degree of disability. And so, one thing that I don't think a lot of people think about when it comes to teleneurology is the use case for teleneurology in the outpatient world.
Mm.
Because when you're thinking about the the tremendous burden it puts on patients and their caregivers oftentimes to come into the office when they are incredibly disabled, to come into the office to find transportation, to find that support. If they're dependent on Medicare transport, I think any patient who's dealt with that knows what a burden that can be. And so I think thinking about teleneurology in unique and innovative ways that can help bridge that gap and help bring the care to the patients where they need it is something that is probably untapped potential in the
Hmm.
telehealth space when it comes to neurology. I think about a patient of mine who had ALS. And so he had Lou Gehrig's disease, and that is a neurodegenerative condition where over time, pretty much from the toes up, you start to lose function. And those folks, as things progress, they end up wheelchair bound because they've lost mobility in their lower extremities. As it continues to progress, they're now ventilator dependent because it's impacted their diaphragm function. So think about that patient coming in for a follow-up visit. They are in an electronic wheelchair with a ventilator, oftentimes with different equipment that helps facilitate communication. And it goes on about, thinking about how that patient gets into that office. And one thing we've been able to do for that patient, I actually was a part of his care team when I was a pulmonary nurse practitioner because we managed his ventilator. But he was very lucky to have found a team of physicians and APPs that were willing to work with him and be seen via tele because it was such a burden for his family, his wife, and his other caregivers to get him to all of these different specialists that he needed to see. And so I think that that's something that um, has really opened the doors for a lot of patients to get the care that they need, where otherwise they would go without it, frankly,
Yeah.
because they just can't do it. They don't have the support to do it.
Yeah, absolutely. Absolutely. And what a great story. So nice we were able to support him in his home environment, keep
Absolutely.
him more comfortable, and
And
also
I'll tell
again
you
the
what,
burden for the
he
family.
is that man is still thriving,
Oh, that's fantastic.
thriving. He has the most amazing support team. Without revealing too much, I mean, he competes in wheelchair races and all sorts of things with his team of caregivers, and he's really, I think, a wonderful ambassador for living with chronic disease like ALS. Because I feel like a lot of times it's a lot of sad stories, of course, but he's somebody I'll always remember. It's
Yeah.
sort of phenomenal what an impact that telehealth has had on his life and his family's life.
Oh, that's amazing. Well, I love that story. And that actually segues really great into my next question, which is what neurological conditions do you think are best suited for telehealth visits?
Yeah.
Is it, can everything be seen via tele? Some things need to be seen in person. What do you think?
So it's a great question. I think that the answer is it's a mixed bag. I think there are a lot of chronic neurologic conditions that can be managed sort of ongoing via tele. One thing that comes to mind, kind of speaking more to conditions that involve disability, is you think about chronic seizure patients, patients who have epilepsy. A lot of times, if you're doing your job well and they're behaving and they're taking their medicines, a lot of their follow up is laboratory checks and symptom checks. And if they're taking their medications, maybe they're on a medicine that requires a laboratory check for levels. And also, maybe we're monitoring their liver function because sometimes that medicine can mess with their liver. So they're doing labs maybe every 3 months if they're nice and stable. So they need an appointment with an APP or a physician that's, hey, your labs look normal. How you feeling? Meds are okay, you're not having side effects. And an appointment that could very easily happen via tele.
Mhm.
I would say there are some diagnostic tests that are used in neurology that need in person, right? And so if you need an EMG or you need, we're doing peripheral nerve testing to see about how signals are traveling from the brain to the periphery, or we need to look at peripheral muscle weakness. So if we're doing a lot of early stage diagnostics, I think those patients are probably more appropriate to be seen in the office. But what I'd like to see is those patients who need those in-person visits not having to wait, because a practice that is appropriately utilizing tele has been able to shift a lot of patients to a telehealth platform, freeing up their waiting room, freeing up their exam rooms for those folks that require
Mhm.
in-person care. So seizure, I touched on that. A lot of think about chronic neurologic conditions like Parkinson's. So
Mhm.
there are some Parkinson's patients, thank goodness, who are stable for a very, very long time. With Parkinson's, we know that mobility is affected over time. We know there can also be cognitive changes. And so that's another situation where I think about the caregiver burden of what it's like to get those patients into the office. So if you've got a patient who's in a pretty steady state with Parkinson's, I think it's appropriate to transition some of those follow-up appointments to telehealth. Now, if you're calling my office and you're saying, gosh, my father, things just don't seem right. Things aren't looking the way that they did 3 months ago. I probably want to see that patient in person. I want to look at their gait. I want to do some strength testing. I want to do some cognitive testing on those patients that is probably best done in person. Multiple sclerosis is another condition that I think requires a lot of touch points with a clinician. That I think some of those could also be done via tele. Another thing that we don't often think about is some of the diagnostic studies that are done in neurology that can be interpreted via tele. And so EEG interpretation. So in order to be an epileptologist, it requires a lot of training. And it's, I believe, an additional 2 fellowships beyond what you do for a normal residency. And so it can be difficult to find clinicians, certainly in more rural areas, that are adept at reading EEGs. And so that's another application of an maybe asynchronous sort of encounter that could help a patient via tele, is to get those answers and those diagnostic readings done remotely, rather than a patient having to wait a long time to get a result
Right.
like that.
And we're certainly seeing that, right? We are seeing offices that are backed up 6, 8,
I
12,
believe it.
nothing worse than calling in, you're scared, you've been given a referral, and the office tells you, we can see you in 4
Yeah,
months. And I think
absolutely.
that this is exactly how tele should be applied, right? You
Yes.
gave a great example, which was, that offices should be offloading a tremendous amount of their appointments, especially follow-up care,
Yes.
standard chronic care, over to tele, making room for the option for those folks that do
Yeah.
need to be seen and do need to have hands-on exams, right, to present
Yep.
and come on in. And I think that is sort of the message that we want to relay, right? We're not saying that everything should go into a
Absolutely.
telehealth model, but that there is a tremendous amount of examination, delivery, diagnostics that can be done through this medium, and it can be done both outpatient and inpatient. And what we really want to garner, honestly, is to make sure that providers are being utilized in the most productive and appropriate way that we can have them, right? So if we have MD care teams, NP care teams, PA care teams, whatever they may be, collaborative teams, right? That everyone is being able to see at the end of the day the most patients, so that we can get everybody through the funnel and ensure that they get a proper diagnosis in a timely fashion. But I think also we would be remiss if we didn't say that we recognize that we're in a provider shortage all the way around. And so we
Absolutely.
do need to be careful about utilize this precious resource, and implementing telehealth programs certainly helps to save that. So for sure. All right, last question for you. How do you see advanced practice providers like yourself, so nurse practitioners or physician assistants, contributing to the future of neurological care? Where do they fit into the model? And what do you think we may see in the future?
I really think, obviously I'm a huge advocate for, practicing to the full extent of your license and training. And so I think in a lot of capacities, what can't an APP do? I think with the right collaborator in my state, because I mentioned I live in a restricted practice state. If you've got a fantastic mentor, whether that is a more senior APP, NP, or PA, or a physician that's willing to walk you through sort of the nuance of that kind of specialty care, it's invaluable. And I think that, when we come out of school and we start to think about where we can have the most impact, I think there's really no limit of what you can do if you're surrounded by the right people to be that resource for you and to provide you with that education. I mean, as a neurocritical care APP, there was no diagnosis that I was, unable to see. There was, obviously outside of a tele perspective, I mean, there were no procedures I was unable to do as long as I got the proper education and training to do them. And I think the same applies for, for tele. I don't think there's any diagnosis that is outside of the scope of a well-educated and trained APP. I think with anything, whether you're an APP or an MD, I think the biggest thing is, to recognize when you need to seek the counsel of a peer, when you've got a complex case. There's no such thing as too many heads in the room. We
Hmm.
always did a multidisciplinary approach. We always said, gosh, this is unusual. Have you seen this before? And what worked? Because this migraine patient, I've tried them on 5 classes of medicines and I can't get them away from a weekly headache. And so I think a lot of times that collaboration is huge. And I think if you build telehealth programs in such a way where there's great continuity of care and there's great rapport among the remote providers and the in-person providers, I feel like you get a really good synergy for that patient care because maybe that in-person provider can help answer a question for that patient that's in the clinic, and you just want one more person to lay eyes on them, right? And so I think that there's really no limit to what an APP can do, in a supportive environment like that.
Yeah, I mean, what a great answer. Very comprehensive. And I agree. I think that as the future of medicine continues to roll on, people get sicker, people are living longer, right? There's less of us to go
Absolutely.
around. And
Yeah.
so I think collaborative care models are definitely the answer to the future of how are we going to take care of America. So listen, I really appreciate your time. This was fantastic. Thank you so much. And hope to the audience that you'll join us next time for our next round of what's going on with telehealth. Thank you so much.
Thank you. All right. Bye bye.